Indication and usage. CALQUENCE is indicated for the treatment of adult patients with chronic lymphocytic leukemia, CLL, or small lymphocytic lymphoma, SLL. Select safety information. Serious adverse events, including fatal events, have occurred with CALQUENCE, including serious and opportunistic infections, hemorrhage, cytopenias, second primary malignancies, cardiac arrhythmias, and hepatotoxicity, including drug-induced liver injury. The most common adverse reactions, greater than or equal to 30%, are upper respiratory tract infection, diarrhea, headache, and musculoskeletal pain. The most common grade 3 or 4 laboratory abnormalities, greater than or equal to 10%, are absolute neutrophil count decreased, uric acid increased, absolute lymphocyte count decreased, and platelets decreased. Please see full important safety information at the end of the video. Please see full prescribing information, including patient information.
Hi, I'm Dr. Susan O'Brien. I'm a professor of medicine at the University of California at Irvine, Chow Family Comprehensive Cancer Center in Orange, California. And I'm going to talk to you today about the 6-year follow-up of the ELEVATE-TN trial. As you can see, 535 adult patients with previously untreated CLL were randomized into 3 arms: CALQUENCE plus obinutuzumab, CALQUENCE monotherapy, or obinutuzumab plus chlorambucil. We will take a look at baseline characteristics in a moment. The primary endpoint at the interim analysis was PFS for CALQUENCE and obinutuzumab versus obinutuzumab and chlorambucil, which was assessed by an independent review committee, or IRC. Select secondary endpoints included IRC-assessed PFS of CALQUENCE monotherapy versus obinutuzumab and chlorambucil, and IRC-assessed overall response rate, overall survival, and safety. At 6-year median follow-up, investigator-assessed PFS, overall response rate, and overall survival were reported. The interim analysis had a median 28.3-month follow-up with a range of 0 to 40.8 months. The long-term analysis had a median follow-up of 74.5 months with a range of 0 to 89 months. The table shows that baseline demographic and disease characteristics were similar and generally well-balanced between treatment arms. The study included a wide range of patient types, many with high-risk genomic features. The interim analysis at 28.3 months follow-up showed an unprecedented progression-free survival benefit with CALQUENCE plus or minus obinutuzumab versus chlorambucil obinutuzumab as a first-line treatment for CLL. There was a 90% PFS risk reduction with CALQUENCE plus obinutuzumab compared to chlorambucil and obinutuzumab, and an 80% PFS risk reduction with CALQUENCE monotherapy. In the long-term analysis of ELEVATE-TN, over approximately 6 years, there was an 86% risk reduction in disease progression or death with CALQUENCE plus obinutuzumab. Please note that the timing of long-term follow-up was not pre-specified, and the analysis was descriptive in nature. What we see in the graph on screen is the estimated percentage of patients who are alive and progression-free in each arm. At 72 months, these percentages were 78% with CALQUENCE and obinutuzumab, 62% with CALQUENCE monotherapy, and 17% with chlorambucil and obinutuzumab. The median PFS was not reached for patients treated with CALQUENCE, with or without obinutuzumab, and was 27.8 months with chlorambucil and obinutuzumab. The ELEVATE-TN data provides me with reassurance regarding selecting CALQUENCE as a first-line treatment option for my appropriate patients. I've observed similar results with CALQUENCE treatment in first-line CLL in my practice, so the data helps reinforce this treatment approach for me. Next, I'd like to discuss the overall survival results. Overall survival was a select secondary endpoint in the ELEVATE-TN study. The estimated 72-month overall survival rates were 84% with CALQUENCE and obinutuzumab, 76% with CALQUENCE monotherapy, and 75% with chlorambucil and obinutuzumab. Of note, a total of 79 patients, or 45%, after progressing on chlorambucil and obinutuzumab, crossed over to the CALQUENCE monotherapy arm. I'd also like to point out that at 74.5-month median follow-up, the overall survival data were immature. Hence, the hazard ratio is not stable and can continue to change as more events occur. Median overall survival was not reached in any treatment arm of the ELEVATE-TN trial at 74.5-month median follow-up. At 28.3-month median follow-up, CALQUENCE and obinutuzumab had superior overall response rate versus chlorambucil plus obinutuzumab. The difference was not statistically significant for CALQUENCE monotherapy versus chlorambucil plus obinutuzumab. Now let's move on to the overall response rate findings at the 74.5-month median follow-up. The CALQUENCE plus obinutuzumab overall response rate was 96%, and there was a combined complete response with incomplete hematologic recovery equal to 37%. The overall response rate for CALQUENCE monotherapy was 90%, and the combined complete response with incomplete hematologic recovery was 19%. The obinutuzumab and chlorambucil arm had an overall response rate of 83% and a combined complete response with incomplete hematologic recovery of 14%. Please note that the timing of long-term follow-up was not pre-specified, and the analysis was descriptive in nature. Before we review the safety data of ELEVATE-TN, I'd like to briefly share PFS observations in specific subgroups. At 28.3-month median follow-up, CALQUENCE plus or minus obinutuzumab delivered consistent PFS results across high-risk subgroups. The results of investigator-assessed PFS in patients with deletion 17p and/or TP53 mutations, typically considered high-risk genomic profiles, are shown in the graph you see here. CALQUENCE with or without obinutuzumab delivered consistent PFS results regardless of 17p deletion or TP53 mutational status. These are important results since approximately 4 to 9% of previously untreated CLL patients present with deletion 17p, and 5 to 12% present with TP53 mutation. Another important CLL feature that has historically affected prognosis is IGHV gene mutation status. An unmutated status has generally predicted a more aggressive clinical course. Up to 60% of previously untreated CLL patients can present with unmutated IGHV status. The PFS rates of first-line CLL patients treated with CALQUENCE based on IGHV status are shown in the graph you see here. CALQUENCE with or without obinutuzumab delivered consistent PFS results regardless of IGHV mutational status. Let's spend time reviewing the long-term safety data from ELEVATE-TN. Safety and tolerability results in the 6-year median follow-up were consistent with the established profile of CALQUENCE. At 74.5-month follow-up, any grade infections at 83%, bleeding at 53%, and second primary malignancies at 20% were reported in patients in the CALQUENCE plus obinutuzumab arm. Any grade infections at 80%, bleeding at 45%, and second primary malignancies at 20% were also reported in patients in the CALQUENCE monotherapy arm. There were low rates of atrial fibrillation, hypertension, and major bleeding. At median 74.5-month follow-up, rate of any grade atrial fibrillation was 7%, hypertension was 11%, and major bleeding was 9% in the CALQUENCE plus obinutuzumab arm. Rate of any grade atrial fibrillation was 9%, hypertension was 11%, and major bleeding was 6% in the CALQUENCE monotherapy arm. I like using CALQUENCE in my patients because it has a very low rate of hypertension, and I've generally not encountered much problem with patients needing, let's say, an increase in their antihypertensives or new antihypertensives. Certainly, atrial fibrillation can occur. I would say it's infrequent, but it does occur. And if I'm going to manage that, I'm going to manage that with a cardiologist. As you can see in the table, at 6-year median follow-up, the most common adverse events of any grade and grade 3 or greater were consistent with the established profile of CALQUENCE, apart from COVID-19 observed during the pandemic. The most common adverse events seen in at least 30% of any grade in the CALQUENCE plus obinutuzumab arm were diarrhea, headache, arthralgia, neutropenia, and fatigue. In the CALQUENCE monotherapy arm, the most common adverse events were diarrhea and headache. The most common adverse events of any grade, meaning those observed in 30% or more of patients, were diarrhea, headache, arthralgia, neutropenia, and fatigue. In terms of managing the adverse events, for diarrhea, I generally use loperamide. The oldest patient that I've ever treated with CALQUENCE was a 90-year-old gentleman, And when we sat down and discussed it, I talked about the side effects. And in particular, I mentioned headache because it's not infrequent and I wanted him to know what he could do if he got a headache. And so I told him he could use aspirin or acetaminophen or even caffeine seems to work quite well, and that the duration, if it occurred, would be pretty short. So the data from the ELEVATE-TN trial, including the 6 years of median follow-up, really reflect what I've seen in my practice. At the interim analysis with a median follow-up of 28.3 months, treatment discontinuation rates due to adverse events were 10% for CALQUENCE monotherapy and 11% for CALQUENCE plus obinutuzumab. In the long-term analysis with a median follow-up of 74.5 months, treatment discontinuation rates due to adverse events were 18% for CALQUENCE monotherapy and 21% for CALQUENCE plus obinutuzumab. Treatment was ongoing in 54% of patients in the CALQUENCE plus obinutuzumab arm and 47% of patients in the CALQUENCE monotherapy arm at the time of the data cutoff of March 3, 2023. In my view, these low discontinuation rates are encouraging. Tolerability is important for treatment, and I'm able to help support my patients with monitoring and management of adverse events. In summary, at 74.5-month median follow-up, the hazard ratio was 0.14 with a 95% confidence interval of 0.1 to 0.2 for CALQUENCE and obinutuzumab versus chlorambucil and obinutuzumab. Estimated 6-year PFS rate with CALQUENCE and obinutuzumab was 78%, and the estimated PFS rate at this time period with CALQUENCE monotherapy was 62%. The estimated 72-month overall survival rates were 84% with CALQUENCE and obinutuzumab and 76% with CALQUENCE monotherapy. Safety and tolerability, aside from COVID-19 that was observed during the pandemic, were consistent with the established safety profile. And the incidence rates of cardiovascular adverse events, including atrial fibrillation and hypertension, and major bleeding were low with CALQUENCE with and without obinutuzumab. Seeing the ELEVATE-TN, including 6-year median follow-up data, has been helpful to inform CLL treatment decisions in my clinical practice because this data adds to the growing body of evidence supporting the use of CALQUENCE as a first-line treatment option. The data from ELEVATE-TN, including the 6 years of median follow-up, do reflect what I've seen in my practice, which is that patients can stay on the drug. The ELEVATE-TN trial showed that both CALQUENCE arms were better than chlorambucil and obinutuzumab, so you can choose whether to use CALQUENCE as a monotherapy or in combination with obinutuzumab. I think an important component of the ELEVATE-TN study that gives me a lot of confidence in the results is this 6-year follow-up. That's a pretty long follow-up in a frontline CLL population, and the data look really excellent. Thanks for watching, and stay tuned for the important safety information for CALQUENCE.
Indication and usage. CALQUENCE is a Bruton tyrosine kinase BTK inhibitor indicated for the treatment of adult patients with chronic lymphocytic leukemia, CLL, or small lymphocytic lymphoma, SLL. Important safety information about CALQUENCE, acalabrutinib tablets. Serious and opportunistic infections. Fatal and serious infections, including opportunistic infections, have occurred in patients with hematologic malignancies treated with CALQUENCE. Serious or grade 3 or higher infections, bacterial, viral, or fungal, occurred in 29% of 2,055 patients exposed to CALQUENCE in clinical trials, most often due to respiratory tract infections, 18% of all patients, including pneumonia in 14%. These infections predominantly occurred in the absence of grade 3 or 4 neutropenia, with neutropenic infection reported in 8% of all patients. Opportunistic infections in recipients of CALQUENCE have included, but are not limited to, hepatitis B virus reactivation, fungal pneumonia, pneumocystis jirovecii pneumonia, Epstein-Barr virus reactivation, cytomegalovirus, and progressive multifocal leukoencephalopathy, PML. Consider prophylaxis in patients who are at increased risk for opportunistic infections. Monitor patients for signs and symptoms of infection and treat promptly. Hemorrhage. Fatal and serious hemorrhagic events have occurred in patients treated with CALQUENCE. Major hemorrhage, serious or grade 3 or higher bleeding, or any central nervous system bleeding, occurred in 4.7% of patients, with fatal hemorrhage occurring in 0.1% of 2,055 patients exposed to CALQUENCE in clinical trials. Bleeding events of any grade, excluding bruising and petechia, occurred in 39% of patients. Use of antithrombotic agents concomitantly with CALQUENCE may further increase the risk of hemorrhage. In clinical trials, major hemorrhage occurred in 5% of patients taking CALQUENCE without antithrombotic agents, and 3.2% of patients taking CALQUENCE with antithrombotic agents. Consider the risks and benefits of antithrombotic agents when co-administered with CALQUENCE. Monitor patients for signs of bleeding. Consider the benefit-risk of withholding CALQUENCE for 3 to 7 days pre- and post-surgery, depending upon the type of surgery and the risk of bleeding. Cytopenias. CALQUENCE can cause grade 3 or 4 cytopenias. Grade 3 or 4 cytopenias included absolute neutrophil count decreased, 28%, absolute lymphocyte count decreased, 10%, hemoglobin decreased, 9%, and platelets decreased, 9%, in 1,758 patients treated with CALQUENCE alone and in combination with obinutuzumab or venetoclax. Grade 4 neutropenia developed in 14% of patients. Monitor complete blood counts regularly during treatment. Interrupt treatment, reduce the dose, or discontinue treatment as warranted. Second primary malignancies. Second primary malignancies, including skin cancers and other solid tumors, occurred in 16% of 2,055 patients exposed to CALQUENCE in clinical trials. The most frequent second primary malignancy was non-melanoma skin cancer, reported in 9% of patients, followed by other solid tumors in 8%, including melanoma, lung cancer, gastrointestinal cancers, and genitourinary cancers, and hematologic malignancies, 1.1%. Fatal second primary malignancies occurred in 0.8% of patients. Monitor patients for the development of second cancers and advise protection from sun exposure. Cardiac arrhythmias. Fatal and serious cardiac arrhythmias have occurred in patients treated with CALQUENCE. Grade 3 or 4 atrial fibrillation or flutter was reported in 2.2% of 2,055 patients treated with CALQUENCE, with all grades of atrial fibrillation or flutter reported in 7% of all patients. Grade 3 or higher ventricular arrhythmia events were reported in 0.5% of patients, including fatal cases in 0.3% of all patients. The risk of arrhythmias may be increased in patients with cardiac risk factors, hypertension, previous arrhythmias, and acute infection. Monitor for symptoms of arrhythmia, for example, palpitations, dizziness, syncope, dyspnea, and manage as appropriate. Hepatotoxicity, including drug-induced liver injury. Hepatotoxicity, including severe, life-threatening, and potentially fatal cases of drug-induced liver injury, DILI, has occurred in patients treated with Bruton tyrosine kinase inhibitors, including CALQUENCE. Evaluate bilirubin and transaminases at baseline and throughout treatment with CALQUENCE. For patients who develop abnormal liver tests after CALQUENCE, monitor more frequently for liver test abnormalities and clinical signs and symptoms of hepatic toxicity. If DILI is suspected, withhold CALQUENCE. Upon confirmation of DILI, discontinue CALQUENCE. Adverse reactions. Chronic lymphocytic leukemia. The most common adverse reactions, greater than or equal to 30% of any grade in patients with CLL in the ELEVATE-TN and ASCEND studies exposed to CALQUENCE, N equals 511, were anemia, neutropenia, thrombocytopenia, headache, upper respiratory tract infection, and diarrhea. Treatment-emergent decreases, all grades of hemoglobin, platelets, and neutrophils were based on laboratory measurements and adverse reactions. In patients with previously untreated CLL in the ELEVATE-TN study exposed to CALQUENCE, N equals 357, fatal adverse reactions that occurred in the absence of disease progression and with onset within 30 days of the last study treatment were reported in 2% for each treatment arm, most often from infection. Serious adverse reactions were reported in 39%, 69 of 178, of patients in the CALQUENCE plus obinutuzumab arm, N equals 178, and 32%, 57 of 179, in the CALQUENCE monotherapy arm, N equals 179, most often due to events of pneumonia, 2.8% to 7%. Adverse reactions led to CALQUENCE dose reduction in 7% and 4% of patients in the CALQUENCE plus obinutuzumab arm and CALQUENCE monotherapy arm, respectively. Adverse reactions led to discontinuation in 11% and 10% of patients, respectively. Increases in creatinine to 1.5 to 3 times the upper limit of normal, ULN, occurred in 3.9% and 2.8% of patients in the CALQUENCE combination arm and monotherapy arm, respectively. In patients with relapsed refractory CLL in the ASCEND study exposed to CALQUENCE, N equals 154, serious adverse reactions occurred in 29% of patients. Serious adverse reactions in greater than 5% of patients who received CALQUENCE include lower respiratory tract infection, 6%. Fatal adverse reactions within 30 days of the last dose of CALQUENCE occurred in 2.6% of patients, including from second primary malignancies and infection. Adverse reactions led to CALQUENCE dose reduction in 3.9% of patients, dose interruptions in 34% of patients, most often due to respiratory tract infections, followed by neutropenia, and discontinuation in 10% of patients, most frequently due to second primary malignancies, followed by infection. Increases in creatinine to 1.5 to 3 times ULN occurred in 1.3% of patients who received CALQUENCE. Drug interactions. Strong CYP3A inhibitors. Avoid co-administration of CALQUENCE with a strong CYP3A inhibitor. If these inhibitors will be used short-term, interrupt CALQUENCE. After discontinuation of strong CYP3A inhibitor for at least 24 hours, resume previous dosage of CALQUENCE. Moderate CYP3A inhibitors. Reduce the dosage of CALQUENCE to 100 milligrams once daily when co-administered with a moderate CYP3A inhibitor. Strong CYP3A inducers. Avoid co-administration of CALQUENCE with a strong CYP3A inducer. If co-administration is unavoidable, increase the dosage of CALQUENCE to 200 milligrams approximately every 12 hours. Specific populations. Based on findings in animals, CALQUENCE may cause fetal harm and dystocia when administered to a pregnant woman. There are no available data in pregnant women to inform the drug-associated risk. Advise pregnant women of the potential risk to a fetus. Pregnancy testing is recommended for females of reproductive potential prior to initiating CALQUENCE therapy. Advise female patients of reproductive potential to use effective contraception during treatment with CALQUENCE and for 1 week following the last dose of CALQUENCE. It is not known if CALQUENCE is present in human milk. Advise lactating women not to breastfeed while taking CALQUENCE and for 2 weeks after the last dose. Avoid use of CALQUENCE in patients with severe hepatic impairment, Child-Pugh Class C. No dosage adjustment of CALQUENCE is recommended in patients with mild, Child-Pugh Class A, or moderate, Child-Pugh Class B hepatic impairment. Please see full prescribing information, including patient information.